Good afternoon, everyone.
Good afternoon.
Good afternoon.
We have quite an interesting day today. Sorry about that. My house is a construction site today. Um, Today's topic is going to be one of the most interesting topic, and yet one of the most longest topic you will ever discuss in this series. So, if you don't mind, we might skip the break for today. We might skip the break. It's all up to you. Or if John would find a way that, he can go through, because we have about 87 slides to go through. Professor John. I just saw him join. Hello? John, can you hear me? John. Let me see what's going on with him. Give me a minute.
All right. Good afternoon, everyone.
Good afternoon, Professor John.
All right. Good.
Yeah, let's get to
Okay.
it,
So
Professor
today
John.
we are looking at a comprehensive guide to complex surgical instruments and endoscopes. So complex surgical instrument and endoscopes is what we are going to look at today. All right. It means we have some instruments that are complex. Advances in many types of surgical instruments have improved patient outcomes and shortened both hospital stay and recovery time. At the same time, the instruments used in these procedures have become more complex and difficult to process. From their origin in early times, surgical instruments have evolved from simple devices to the complex surgical instrument used today. Forceps, scissors, needle holders, and retractors, along with numerous other simple instruments, are still commonly used, but they are joined by powered surgical instruments, endoscopes, and other highly sophisticated and dedicated devices with complex components such as circuits, boards, and then computer chips. So basically what we are talking about here is with the advancement of medicine, we have graduated or we have moved from simple instruments to complex ones that uses electrical power, and then some also uses what? Scopes or lenses. So those are the complex ones that we want to look at today. Unlike the scissors, the needle holders, which are basic ones, these ones are a little bit complex. Next slide, Director. All right. So the role of this technician in this complex and or powered surgical instrument or endoscopes. So central sterile technician play a crucial role in cleaning, inspecting, sterilization, and maintaining these instruments. Proper processing is essential to prevent contamination, infection, and then equipment malfunction during surgery. So what you see, the pictures you see there, it looks like a gun. That is a powered surgical instrument. A powered surgical instrument. So if you open it, figure 11.1 shows you all the various components that the figure 1.2, 11.2 shows you that the instrument has been damaged because of fluid what? Invasion. It has been destroyed because water that is not supposed to go in went in. Then the figure 11.3 is material components damaged by fluid, also fluid invasion. So
Are we able to get it?
So simply put, powered equipment or powered surgical instrument, we should not allow water to go in them. That is why along the line you will see that they are not supposed to be immersed. They are not supposed to be left in the water for long hours or long period of time. Next slide, Director. Good. So how did we get here? How did we get to surgical, complex surgical instrument? So early surgical instrument, basic, we have all accepted that. Scissors, needle holder, forceps, adhesive with teeth, Coker, Kelly, all that we saw yesterday. Very, very simple. But because of the advancement of medicine, we have they came about with some surgical instrument which uses some electrical energy on air energy and the rest. So powered surgical instrument, they are the drills, saws, and handpieces. One is what we just saw in the figures 11.1, 11.2, and 11.3. That is an example of a powered surgical drill or handpiece. Then we have endoscopic and robotic assisted devices. Endoscopic means it goes inside your body. And then robotic means that the machine is controlling it. Okay, with the press of a button, the machine is doing the work. All right, so that is how far we have evolved as human beings with regards to medicine or health of the human being. Then we have smart instruments. It says some contain circuit boards, sensors, and microchips for enhanced functionality. So we have, in some particular cases, they have some devices, some instruments have devices that help to better serve the patient properly. And all of these needs to be clean. That is why it becomes so complex when you are dealing with them. So processing challenges increase as instruments become more delicate and complex. But that is not to say that because they are complex, we are not going to do it. We are going to cut corners. No, we still have to follow the laid down procedure by the facility or the IFU as instructed by the manufacturer. Any questions so far? All right, next slide. Importance of proper processing. We cannot overemphasize this. It is important whether it's simple, complex, very delicate. We have to follow laid down procedure and standard protocol. So infection control prevent importance of proper processing is to prevent infection. Okay, so what is the role here? They say prevent cross-contamination and hospital-acquired infection, which we call HAIS. So infection control is very mindful of this complex instrument. They know that cleaning them is difficult. So they are very, very curious. They want to know what goes on when a powered surgical instrument is bought. When a flexible or an endoscope is acquired, they want to know, they want to see the IFU just so they can prevent infection on the patient. Maintain instrument longevity. Proper care prevents damage. If you go by the laid down standard procedure in processing them, you increase the lifespan of the instrument. We saw that yesterday, that we should not, if we allow blood to dry on them, they will rust. It will take a long time to clean, and you have to apply too much force, you damage them. The same thing applies to this complex instrument. So if you can, the simple ones can damage, you can imagine the rate at which the complex and delicate ones can go down quickly. Then financial impact. That's another important reason why we have to pay attention to what we are doing and follow standard protocol. The financial impact is so great. I told you yesterday that one instrument can cost like, say, $50,000. That is your whole annual income that you make or somebody makes, and some people even make less than that. So if an instrument can cost that, you need to pay attention to what you're doing. So proper handling can lead to improper handling can lead to costly repairs and replacement. All right. And patient safety. If you don't process the complex instrument well, you cut corners and you leave microorganisms or biobedding, you infect the patient, and then the patient has to come back and he can sue the hospital, so the financial impact comes into place, and then the life of the patient is also being impacted negatively. So when you go to the job, pay attention to the complex instrument reprocessing. Next slide. Good. Powered surgical instruments. Powered. Used in neurosurgery, orthopedics, otology, that is ear, and then dentistry. Yeah. So the dentist, you hear, they are drilling your teeth and what have you. If you pass by the OR and you hear those strange sounds, it means they are using the powered stuff. Okay. Examples are high-speed drills for brain and spinal surgeries, bone saws for old joint replacement and trauma surgery. So the bone saws, you use the cut bones, they use it, the blade, they mount it on an attachment that is mounted on a handpiece, and then they saw the bone, they cut it. Maybe if you're doing amputation, you have diabetes and your leg is getting bad, they amputate you, they cut all of this. They use the bones, the saws to do that. Powered handpieces for precise dental work. So when you come to CSPD and you are dealing with powered instrument, you see a variety of them from different vendors. Stryker, we have Wright Medical, we have Synthes, we have Linvatec, and a host of them. So you will be given training, so don't be scared, but they need special attention and they are very expensive. So they don't have to be treated lightly. Okay. When you buy an expensive car, you make sure that you get it, you keep it nice, because when it goes, you have to go to the repair shop, you're going to put your hands deep into your pocket. Same thing applies to the hospital system. Benefits of powered instruments. It reduces surgical time. Yes. Instead of using the surgeon uses his hand to cut with a knife or whatever, or with a powered instrument, you just press a trigger, or you pull the trigger, you press some button, and then within seconds, the cutting is done. Within seconds, the cutting is done. All right. So it reduces surgical time and minimizes physical effort needed by the surgeon. Explanatory. It's very simple. When you use machine, it's quicker, it's safer to get out. All right. Enhances precision. Yes. So the machine will enhance precision, allowing for more delicate and accurate procedures to be done. You're not going to be going manual. All right. I don't know how many manual cars are still in the system. Almost everything is automatic. You put it to drive, you are gone. So almost everybody is a driver now. All right. So that's how surgical instruments have evolved. Once the more complex one come, they make it easier, and we get it right away. Less invasive, leading to faster recovery times for patients. Less invasive, meaning that it reduces the amount of time you go in and come out. So because they are so precise, you get it right on the first attempt. You don't have to do try and error. Okay. So, and once you get it at the first time, the recovery, or you get it on the spot, it helps the patients to recover. So when you use these complex but powered surgical instruments, surgery is done in quick time, in record time. Recovery is also what? Done in record time. Okay. Any questions so far? Any question?
No.
All right. Great. Let's go. Writer. Don't hesitate to ask if you have any question. Don't hesitate. All right. Feel free, ask. Then we serve you better. Cleaning and maintenance. This is where the issue is. How do we clean it? How do we maintain it? So use enzymatic agents to break down biological debris. So because these drills are handled by the surgeon, the surgeon is the one who holds it and does work with it. So it comes out bloody. So we have to use enzymatic detergents to break down those tissues. Ultrasonic cleaning is effective for hard to reach areas. So yes, but you have to follow the IFU of the instrument. If it is not supposed to go into the ultrasound, you don't do that. If it is supposed to go to it, it will be stated. Okay, you do not have to say manual brushing may be required for intricate components like lumens and channels. Yes, you will have to use brush, the appropriate brush, okay, to go into the hard to reach areas. That's what it means by intricate. Hard to reach areas, you have to use brush. Your finger, it probably is bigger than the place, so you can. So use a brush and then help clear the place and then flash whatever you need to flash. But I want to caution everybody here that when it comes to powered surgical instruments, please be mindful. Do not immerse in water. Do not soak it. We know from the onset that if you are working in decontamination, you have to soak your instrument. But when it comes to surgical instrument, powered surgical instrument, you don't soak them. All right, you don't leave them you soak them, cannot leave them for hours. You soak them and go for break, go and spend 1.5 hours. By the time you come, the liquid or the fluid has evaded your system, and then you damage whatever it is. Okay, so put it there, 2 minutes, 5 minutes maximum, clean it out, and then you're out. Okay, don't leave it there for hours. Lubricating, yes. Some parts of the power surgical instrument needs to be lubricated. All right, you will get training as to how to do it, or in some cases they have a vendor rep or the manufacturer rep is on the spot, on the site, who does some of these jobs. So you either watch him or her do it and learn from it, so that in the event that the person is not there, you can maintain and prolong the life of these powered equipment. So they need to be lubricated, because they are spinning. Their working mechanism is spinning. Okay, so if you don't lubricate them, what happens? The spinning can become stiff, and it will not spin, and that means that the surgeon cannot use it. Use only manufactured approved product to avoid residual buildup. So detergent selection, it will always tell you neutral pH. Okay, then it will give you what the lubricant is. For example, in my department, I have Linvatec, I have Stryker, I have Ride Medical, I have Trudy, I have Osada. These are all surgical instruments that uses electrical energy, and they are all treated differently. So for these 5 instruments I have just mentioned, that is what I use in my facility. They both have the lubricants that they use. They don't use the same one. So you have to use the appropriate lubricant for the exact piece that you are working with. So when you get to the department, learn, it will help you. Inspection and testing. Check for cracks, corrosion, worn out parts, or electrical malfunction. So check for cracks, check for what? Corrosion, it is fading, it's get stiff, the trigger is not working, check for all of that. Loose parts hanging, check that. Okay, the cord is broken, it means that somebody can get electrocuted, check that. Ensure battery powered instruments are fully functional before sterilization. So some that uses, we'll come to see that some uses battery in the process to power the instrument. So we have to check it to make sure that they are functioning. You load the battery on it and then pull the trigger to see if you can hear the spin or the noise that it's supposed to make. Okay, this surgical instrument comes with different attachments. Each attachment has its own sound. So as you work with them, you get used to it. Don't just be scared with all this gazillion of information I'm giving to you. Just listen, read after this, and when you get to the department, the rest of it will be taken care of by your experienced senior staff and the manager. They will teach you how to navigate around all this information we are giving you. So, but you'll have to lubricate it, check for cracks, just as we do for simple, basic instrument. Lubricate them when you detect that certain parts of them are becoming too difficult to function. Any question before we get to the next slide? All right, next slide, Director. Steam sterilization method. Sterilization method. So for these complex instruments, we have the steam sterilization, or what we call high temperature sterilization. It's the same as autoclaving. All right, it's the most effective, the most recommended sterilization method. Okay, the most recommended sterilization method, but not everything goes through steam sterilization, so you have to be mindful of that. Again, your IFU will indicate. So effective for heat-resistant metal instruments. So if the instrument cannot resist a temperature of 270 degrees, you cannot put inside the steam machine to be sterilized. Not suitable for delicate electronic components. Obviously, yes. Yes. Unless the IFU says that. So if you cannot go and put a camera in the steam to sterilize. But some cameras go through steam if the manufacturer says so. Low temperature sterilization. Low temperature sterilization, which is called also heat sensitive instrument. It means that they cannot withstand heat. If the heat goes above a certain level, they melt. Example of low temperature sterilization is hydrogen peroxide gas plasma, which we call STERRAD. If you get to know the STERRAD processing technique is low temperature, used for electrical, battery, and battery powered instruments. So those that cannot withstand the heat from the steam, they go through the low temperature. Okay, and we also have ethylene oxide. Ethylene oxide, we talked about it the last time. It's used in places where a lot of cancer cases are taken care of. It has a bad odor. It is, you need to wear a certain device so that when the alarm starts going off, it's measured, and then you have to remove yourself from that place, because if you inhale it, you can get sick. So low temperature sterilization, high temperature or steam sterilization, and then we also have the ethylene oxide method of sterilization. You cannot decide on what method to use unless the IFU says so. So that is why whenever a new instrument is acquired, the rep or somebody from the manufacturer comes to give in service and tell us how to get around it. Next slide. Challenges in instrument processing. Challenges in instrument processing. Handling delicate instruments. How do you handle somebody who is delicate? You have to go with what? Care and love. You have to give it all your attention, because if you are absent-minded, something will happen. So many instruments contain small internal parts like sensors, chips, and tiny motors. Rough handling or improper cleaning can cause mechanical malfunction. So the one we saw earlier, 11.1, figure 12.1, it has different components in there. You allow water to go in, it's done. Most of the electrical stuff, water goes in, it's done. You can't do anything. You can't recover it. And if you do, it's going to be very, very costly. Sometimes it's even cheaper to replace the whole piece than to repair it. That is how bad sometimes it is. Okay, so you have to handle it with what? Care. Again, don't guesswork. Ask questions. Ask for help if you need to. All right, if you need to, ask for help so that they will help you to be able to do the right thing. Manufacturer-specific requirement. Each powered instrument has a unique cleaning and sterilization process. We mentioned that already. You can get that by following the IFU. Technicians must stay updated on IFU changes and new processing guidelines. Yes, even if you know how an instrument is cleaned, if for any reason the manufacturer thinks that they did not get certain things right from the beginning, and therefore once a change in the cleaning and sterilization process, they will send an updated version of the IFU to all the hospitals that use that instrument. And when that happens, the management will have to come back and re-educate everybody who knows how to handle it. And you have to pay attention to the new information that is being given. That's why we say that we have to stay updated, because what you know may have changed. What you know may have changed. That's why I couldn't tell you yesterday that certain questions were coming. There is time sensitive. Surgeries rely on quick instrument turnaround, requiring sufficient but thorough processing. Time sensitive. Surgeries rely on quick instrument turnaround. Okay, so we have to, these are the challenges, because the instruments are not enough. The surgeons want to do so many cases, so they want us to quickly reprocess those instruments, make them available for use. So people hide behind that. You will find people hiding behind that when you start working to cut corners. And when you cut corners, what happens? You get into trouble. Okay, you get into trouble. You bring a delegate to your manager's office. Nobody want to do that. So the rash cleaning or sterilization and can lead to contamination or malfunction. All right. So even though you don't have enough and you have overbooked the surgeries, you still have to do it the right way. Because if you don't do it that way, you are going to damage the handpiece or the instrument. High cost of repairs and replacements. I mentioned that earlier. Very expensive. One probe we have in my hospital, it costs about $50,000. One. Okay. So it cannot be steamed, or it cannot go through high temperature sterilization. So if you make a mistake, you put it there, boom, you just incurred a cost of that to the hospital. Then instrument preventive maintenance extends the instrument lifespan. Can overemphasize that. You keep it properly, it lasts longer. If you always take maintain your car. It always sounds new. It always look new. If you don't maintain your car properly, what happens? It looks wretched, and sometimes you don't enjoy driving it. You see somebody's car, and then you are like, I wish I had this one. You could keep yours the same way. So please, let's do the right thing when we get into the department. Any question before we get to the next slide? I will soon be calling some people to help me when I get tired. For now, let me deal with it. Best practices for CS technician. Follow strict decontamination protocols. Strict. The word is strict. Follow strict decontamination protocols. All right? Yes. The items, you go there, decontamination protocol, dress well, soak, brush, flash, sonic if need be. All right? Don't cut corners. Don't go and just put it under running water and put it by the window and say it is done. Okay? No. Inspect instrument carefully, looking for cracks, misalignment, corrosion, and battery defects. Okay? Look for misalignment, corrosion. If there are any cracks, any loose parts, notify the manager immediately so that if they can replace it or they take it out of service for maintenance. Test mechanical and electrical functions before sterilization. We did mention that earlier. The next point is use correct sterilization method. Again, before you get to the department, the sterilization method is there. If you're confused, ask. If you are confused, ask. And most of the hospitals have IFUs. You can easily look for the IFU of the instrument on the net, using your workstation. All right? You can get it from one source. I don't want to bother you with what is one source. When you get to your workplace, you get to know what is one source. It means that you can get a whole lot at one place. Okay? Right. Ensure proper storage and trays or cases to prevent damage. Delicate instruments, we protect them. Sometimes they are tips, we protect their tips. Their tips are so fine and delicate that if we let them loose in the tray or in the basket, and then they are transported or they pass through several hands, they can get damage. So we protect them. Sometimes we have a soft mat in the basket, or even before they go onto the mat, they are also put in they have tips that are protected. We have some silicone rubber tips that will protect them so that their tips, even if they hit the walls of the basket, they won't get damaged. All because that is what the IFU is recommending. Okay. Then, to be able to do the right thing, we must attend training. In services, we have to. All right. Oh, I've been here 25 years, 50 years. I know it all. Mr. Know It All. You don't know it all because every year you have to get recertified, and you have to, your manager or the educator for the hospital will have to present what we call continuous education points. And where do you get these continuous education points? You get them from the in-services that you attend. It's documented and reported to the certification board that will recertify you. Okay, so please take advantage of this training. Forget about the number of years you will be on the job. Take it and move with it. Any question before we go to the next slide? Good. Processing and handling of powered surgical instruments. Again, I mentioned that no water you should not allow water to go into your powered surgical instrument. Very expensive. So don't leave them in the water soaking and then go for lunch. A lot of the time, that's what happens. People dip the thing is it can be soaked, so they put it there and then go take 1 hour lunch. Sometimes if there's no supervisor around, he makes it 1 hour 15 minutes, 1 hour 30 minutes. By the time you come, your instrument has swallowed a lot of what? Fluid. And therefore, even before you wash it and put it by the window, you have already, killed the instrument, if I may put it that way. All right. So power surgical instruments avoid fluid invasions. Avoid fluid invasion. Common signs of fluid invasion damage include malfunctioning handpiece. Yes, it will malfunction. You take it to the room, they plug it, they press the trigger, no movement, dead completely. What happens? Case is delayed. More work is created because you cut corners or you did the wrong thing. Internal corrosion of electrical components. So what is not supposed to be there made its way into the place. So it starts what? Corroding the place. Reduce performance or complete failure of the instrument. Almost the same as malfunctioning. How do we prevent that? How can we make sure that we don't allow water to evade or fluid to enter into the powered surgical instrument? Never submerge. I don't even want to read the whole thing because I have mentioned it already. Always ensure cable, hoses, and connectors remain dry. Okay. Cables and connectors. Cables and hoses. Hoses have lumens in them, and water is not supposed to go into them. So you're not supposed to immerse them. All right. Be mindful. Store instrument properly to prevent condensation buildup. So you got to store them in a right and proper way so that it will not build up any condensation of any sort. So you will get to know the hoses, or we might see them along the line in the picture somewhere in our discussion. Questions so far? Questions so far? Questions so far? All right. Silence, they say, means it's sinking in. Let's move on. Later. All right. So we have 3 kinds of powered surgical instruments. The one that is powered by electric, the one that is powered by air, which we call pneumatic. We have the one that is powered by what? Battery. So electric power, air power, and battery powered. These are the 3. Pneumatic is the air one. Okay, let's go see how they are. Next slide. Electric power. So commonly used in maxillofacial, dental, and small bone procedures. So maxillofacial, that is it's kind of in the skull, neuro and those stuff. Okay, some part of ENT, head, nose, ear, nose, and throat section of your body. Dental, the mouth. Then small bones procedures. The bones are in your skeletal distance, so that comes to maybe orthopedic stuff. All right, where lightweight instruments are needed. Okay. It requires sterilization power cable that. Oh no, sorry. Require a sterilizable power cable. Yes, we have to sterilize the power cable because the power cable is going to come into contact or into the sterile field. So it has to be sterilized to make sure that it is devoid of any viruses or any contaminant. All right, that's why we sterilize the cable that produces or that the power of electricity passes through. Example is arthroscopic shaver used in orthopedic procedure. We'll see the shaver, I'm sure, somewhere along the line. Can't describe it for you to see right now. It has a cable that is joined to the shaver, and that is connected to a machine which calls console, right? That produces the energy for this to work. Arthroscopy shaver means that they use it to shave some bones or to shave certain parts. Challenges with this electrical powered instrument is fluid invasion. So the shaver in my hospital, you don't pass it through the washer, we hand wash it. So it is manually washed. You use your hand to wash it so that you can expand, prolong the lifespan of the instrument. Condensation damage when the instrument seals degrade. All right. When instrument seals degrade. When the seals that are supposed to be in place, what is going to happen is that when steam goes in there, it's going to invade your system. So you got to pay attention. Electrical contact wearing out over time. Yes. Yes. Sometimes the electrical parts, there will be a nick. There will be a cut on the the cord. You need to check the whole length of the cord. Use your hand to feel it. If there's a nick somewhere, you feel a bump in your thumb. All right. And then when you are some of these cords, you are going to electrical cord, you're supposed to coil them into the basket where you are assembling. Don't coil them too tight. Don't coil them too tight. You coil them too tight, you are kind of reducing the lifespan, because the more tight they become, the more easy they break inside, and then you will not know. Everything is out looking good from outside, they plug it and it's not working because everything has broken inside because of the way you coil it so tight. So the electrical wear out, or the electrically wear out over time. As they continue to use them, they will wear out. All right. Next slide. Best practices. It's all about what to do right. IFU. So you see how important IFU is? Oh, the only time we didn't see IFU probably was when we're talking about microorganisms. Yes, probably when you were dealing with that, and then the skeletal system, you probably wouldn't see IFU. After that, everything is IFU here, IFU there. So pay attention. So you will see this. So it means that an IFU is one question out of the 150 questions you see there. Okay. So manufacturer approved brushes for lumens and distal tips. So you have to use the appropriate brushes. If a distal tip has a plastic piece, you cannot use a metal brush. You have to use a brittle brush that is sensitive, or that can easily clean the plastic part without having to cause bruises on it. So don't use the metal. Use the appropriate brush to do that. Avoid using inappropriate solvent or lubricants that may damage internal components. So like I told you, in my department, I mentioned so far 5 powered surgical implements. Each of them have their own lubricant. You cannot use Osada's one for Trudy. Same way you cannot use Trudy for Comet. You cannot use Comet's lubricant for what? Striker. That's how it is. Okay, so stay put. Be very, very attentive to whatever you're doing, and then you get it right. Dry instrument cloth after cleaning. It can cause a problem. Data. Hello?
Yeah, I'm here.
Good.
What was the question?
I don't know what happened to the slide.
Oh, something happened?
Yeah.
I went back or forward? Yeah, best
No,
practices.
we didn't finish the slide. Yeah. The best
Okay.
practices and addition.
Yeah, this is where we were. Is this not
Okay.
where we were?
Hold on.
Okay.
The slide is
Let
not
us see.
sharing. The slide is not sharing.
It's not sharing, right?
Oh, it's not
Am I
showing?
the only person struggling?
No, I
Yeah,
cannot see
it
it.
is
We
not.
cannot
You are
see
seeing a
it.
blank
Oh,
screen.
sorry about that.
Mm.
Okay. Best
All right. Thank
practices.
God I'm not alone in that. That this is yes. All right.
Yeah, now it's
Good.
fine.
Now it's
Yes,
on. All right, good. Thank you, Data.
Yeah, you're welcome.
Thank you so much. So that is why you cannot use any lubricant other than the one recommended by the manufacturer. So dry lint comes from the towels that we use. Sometimes the sponges we use to do the hand washing in the decontent. Or sometimes when the piece that is washed still has moisture, you want to clean it before you put it together. The towel you might use might have what? Lint. So we try to use lint-free what? Towels to clean them so that we don't leave lint behind. Lint, it was one of the infectious what? Pieces that were getting patients back to the hospital. Inspect cables for cut, bends, or exposed wiring before and after each one use. I mentioned that earlier. When applicable, connect the power cable to the handpiece during cleaning to avoid fluid penetration. Yes. When we come to the decontent part, this point is very important. When you connect the power cable, you prevent water from going into the electrical connection part. Therefore, it's not going to get damaged whilst you are cleaning it. All right. Next slide, please.
For the what is the
Lint. Okay. All right. So yes, lint is the pieces of on your skin.
Yeah, that's true.
yeah, that's true.
Okay, that is
Explain
lint.
now.
That's the
Explain.
best way I can explain it for you. So that is lint. All
Explain.
right. So when
Explain.
this is left on the piece, it can go into the patient system. All right.
Yes,
Have I
sir.
made myself clear?
Yes, sir.
All right. Good. Awesome. Let's go. Next slide, Data. All right. Now, because it is the powered instruments are using electricals, they are either operated using the hand or they have some paddles that they step on. If you go to you have ever taken your maybe your new clothes to a tailor or your body piece, the tailor, you go, some tailors have some paddles or they step on some, they have some is done using electrical. So in the case of the medical field, we have foot paddles that the surgeon steps on that powers the instrument that he is using. They powers it. Okay. Some places it is the hand, he presses a certain clip and then it powers it. So we have the foot paddles control certain powered instruments. All right. For example, about 80% of them have foot paddles. About 80% of them have foot paddles that you have to use. Okay, can be wired or wireless. All right, most of them are always wired. About 80% of them are wired. Okay, that is not to say you will not find one is wireless. You will find one. The one that has wireless, it has battery using it for that. Okay, risk of damage, fluid invasion. We have seen that already. Stress on power cords. That is where you coil it too tight. That's when all the disc happen. When you coil it too tight, it can break inside and then you will not get power. It will not be able to sense any power coming through. Care and maintenance follow again. Manufacturer guidelines is the same as IFU. Avoid pulling on the cable or bending connectors. Who do you think avoid pulling on the cable? Who do you think will be the most culprit on this point? Who do you think will be the one who will be a culprit here?
CSPD technicians?
No. Who will be the culprit? One more guess, and I'll give you the answer.
The deacon.
No.
The
No,
doctors?
operating room.
The operating room. Thank you. The operating room. You are not in there. They have to disconnect it. So they do the pulling. Okay? They do the pulling. They do the connection. So they take it out. So the pulling happens over there. So they also get education. They get, when powered instruments come in, they also do the in-service. They are trained how to connect it, how to disconnect it, how to carry it to decontaminate, all of that. So this part goes to the OR, all right? And the OR will always come say that it wasn't me, all right? They always do that. Ensure wireless foot paddles have fully charged batteries before procedure. So if a foot paddle is not using direct electrical power, it needs to be charged the day before the surgery so that it is fully charged. And you must see that the indication which is telling you is fully charged must show for you to confirm that indeed it is charged. If not, in the middle of the case, the machine goes fwing, we are in trouble. Okay? You have to now panic. You'll be pressing the panic button, calling other locations, trying to get one. Because some of these take like 5 hours to charge. That's why you have to charge it before the day of the surgery. All right, next slide. Pneumatic air. So we have looked at the electrical part. We are coming to the pneumatic part. Those that uses air. Those are the ones that uses the hoses. They either have the air, compressed air in the tank, or the air is already embedded in the wall of the OR. The OR is a very nice place to go. You go in there, you marvel. You lift your head, you turn your neck, and then see so many gadgets in there. All right. So the air, some of hospitals have the air inside the wall with the connecting part on the wall. Okay. So you connect it, and then you connect to the handpiece. The air will power it. Some also have cylinders in the OR that they connect the hose to the cylinder, and then they compress. They use the air to get the power, the instrument to work. Sorry. So which powered instrument uses the air? One is the sternum saw for cardiac specialist. Sternum saw for cardiac, and not only cardiac, they also use them for vascular cases. Vascular cases too, they can use the sternum saw for amputation. If you have diabetes and your leg is being rotten or what have you, they just save you the headache of chopping it off for you. All right. So sternum saw for cardiac, you have to cut open your thoracic region. They use the sternum saw. Okay, they can't use a knife, all right, or blade. They'll take 1 year to do the surgery. Then surgical saws, sagittal saws and drills for orthopedic procedures. So they also use that. Okay. So in my hospital right now, which we have one, Dermatome also uses that. Dermato also uses pneumatic what? Power to shave the skin of somebody. All right. How pneumatic instrument work? Operate using compressed air, usually supplied from a stand-alone gas cylinder or a wall or column-mounted regulator. I've already explained that. Either it is in the wall or they have a cylinder, stand-alone cylinder where the connection is done, and then they use it. The air is what is causing the instrument to spin and do its work. So we have looked at electrical, we have now seen pneumatic. Let's go. Next slide, Director. All right. Now, sterilization. We have to sterilize the hose. The hose is in the case of the electrical, the hose is the connector too, from air, the source of power to the handpiece. The cord is the electrical one, the hose is the pneumatic one. Because the hose has channel that air has to go through to be able to power the instrument, you must always make sure that you don't allow water to go in. Because if water goes in and you connect it, what happens? When the
Electrical
instrument
shock.
is being used, the water that was sitting in the hose is the first thing to come out. So you contaminate or you infect somebody with it. So we always ensure that water does not go into the hose. Challenges in maintaining hose. Hoses are often black, for sure. You will see them when you get there or maybe down the line in today's discussion, making it difficult to detect blood or debris contamination. Small nicks or cuts can lead to air leaks, reducing efficiency. Yes. Small nicks. When you coil it too hard or they let sharp objects sit on the hose in the process of transportation from the OR to the decontent, they can puncture holes in them. And when you puncture holes, what happens? Air will be escaping. Therefore, the instrument will not be functioning the way it is because the force with it, the air is coming, is not coming the way because part of it is escaping. All right. If the whole casting appears damaged or bubbled, it must be taken out of what? Service. So the whole casting or casing appears damaged. So if you notice any damage, either at the connecting ends, please take it out of service. Okay, take it out of service so that it can be replaced. Inspection: use an air source to pressurize hoses and check for leaks or debris before what? Sterilization. So in some hospitals, they have air tanks that we can use to check whether the hose is functioning. Okay. But not all hospitals have that. So do not allow fluid to enter. I won't finish reading. I've said that already during cleaning because that can damage and can infect somebody. Connect the hose to the handpiece during processing to prevent fluid invasion. Yes, you can do that. You can connect it so that you clean the handpiece and then you clean the hose as well. All right. All of these items are most of the time hand wash, but that is not to say that the manufacturer cannot say it can go through the wash. Where the manufacturer says so, do it as instructed. But most of them are hand washed. Next slide, Director. Okay. Next slide. I think we took care of this one. Testing and operating.
Can you all see the slide? Sorry, I'm having a little bit of network issues here.
Not yet. Okay. Yeah, we are there.
Sorry about that. I'm having network issue. There's construction going on in my house, and they had to take one of the routers down, and it's affecting my connectivity. I apologize.
All right. So, general best practices for powered instrument. All of these have been mentioned already. Prevent fluid invasion. To do that, you follow the IFU. You use the cable to connect it to prevent. You must lubricate the parts that need to be lubricated as instructed by the manufacturer. That is point 2. Use the appropriate brush to reach very hard to reach areas or intricate areas. Okay. Ensure all moving parts are free from debris. Yes. Thorough inspection. Check for wear and tear, corrosion, and damaged seals. Test functionality before sterilizing the instrument, especially the ones with battery. You don't lose anything. Just get a battery that is charged, connect it, make sure you do that. Okay. Functionality before sterilization. Inspect. I think we took this slide already, right, Data? It looks like. Give me the next one. Looks like we are repeating. Okay, I think this is where we were before. So follow manufacturer's IFU. Always adhere to it. Approved sterilization method. If it is steam, don't go and put it in sterile because the hydrogen peroxide can damage the materials. That's why you have to follow the IFU. Ensure proper storage and handling. Store instruments or protective or containers. Okay. Keep battery-powered devices charged and ready for use. Next slide. Okay, powered surgical instruments are complex and require specialized handling. We saw that. We saw that already. Proper processing, inspecting, and maintenance of our critical. Sorry. So if you don't follow the right instruction or the right way to doing it, you are going to damage the handpiece, whether electrical, pneumatic, or battery powered. Okay, we cannot overemphasize that. We have mentioned it several times. Fluid invasion, lubricating, checking for cracks, checking for nicks, and all of that will prolong the lifespan of the instrument. Your role is to follow the protocols as given. You get to the department, the protocols will be there. You understudy people for at least a month before you can stand on your own. And when you are standing on your own, you still have to ask for help where you feel you are confused. You don't know what to do. It's not a shame to ask for help. If you don't ask for help and you make a mistake and you are being disciplined, you look stupid because you could have asked for help and you didn't do it. You didn't take advantage of it. So always take advantage, ask for help. And when you ask for help, make sure that you keep that information and so that next time you apply it to your job. Next slide. I'm gonna be doing the okay, hold on. Go back. Looks like all right. It looks like we missed the battery part. So we have the battery powered. I'm just going to give you a rundown before we get to the endoscopy part of the surgical instrument. So with the battery, it is powered by a battery. The battery needs to be charged. So the battery, it means that the the surgeon does not, you don't need a foot paddle to do that because the battery connects to the handpiece. So the surgeon holds it. So most of the time, when they're doing the case, they have 2 batteries in the room. So that if the one that they are using goes down in terms of energy, they load it with the new one. So you always have to charge the battery. There's a charging system in the department that you will work in if you are privileged to do so. So before you sterilize your battery, you have to make sure that it is charged. And then you use the battery that is charged to test to see the functionality of your handpiece. Okay? So you have to check for functionality, make sure that where it needs to be lubricated is lubricated, and then you test to make sure that it is working. Sometimes, based on the IFU, the manufacturer will say you can sterilize the battery with the handpiece together. Then separately, the battery power will go through the low temperature, and then the handpiece will go through high temperature or steam sterilization. The difference is not big compared to the electrical and then the pneumatic. Same thing, you must not allow liquid or fluid to invade the system. It will damage it. It won't work. It won't work. And everybody will be panicking when the surgeon is pissed off in the room. So make sure that you don't soak it and go for lunch, or you don't soak it and unattended to. All right? Even though water is supposed to touch it, it must not be left in water for several hours unattended to. So their treatment is basically the same. Fluid invasion is the #1 cause of powered surgical damage. Fluid invasion is more likely you might see a question like that. Fluid invasion is the most cause of powered surgical instrument damage. Next, so take me now to the endoscopes so that I can do the introduction. Yes. Endoscopes. Endo means what? Inside. Scope. So to see what is inside. So most of the endoscopes are used for visualization of the internal organs or certain parts of the DC. We have a variety of them. So we are going to look at that before we introduce. Maybe by the end of this slide, we will take a break and then we come back 50 minutes later. So endoscopes means looking inside, referring to medical procedures that allow visualization of internal body structures using a specialized instrument called endoscope. So we have a lot of them. We have flexible ones, we have rigid ones, we have semi-rigid ones. Okay, so we'll get to see all of them. We may not be able to take all of them today because there are so many that you can't finish all of them. We'll just give you an idea of how it looks like, how it is supposed to be taken care of. When you come down to the floor, to the hospital, you will get to see them and you will appreciate what we are telling you now. Minimally invasive surgery. Endoscope procedures require small incisions or natural body openings. Okay, and what do they do? Reduce recovery time. So minimally invasive means that they don't split open you so big. They just create a small hole, all right, with a puncture of maybe a knife, and then they can insert the endoscope through that small opening, do whatever they need to do in your body, and get out. That's what we call minimally invasive. They use the scope to see on the monitor or the TV. If to make it easier for everybody, there's a TV that we call monitor in the room, like your computer. The image, all your internal organs will be showing there, and then the surgeon is working on it. It doesn't have to open you so big so that it takes longer time for you to heal. So that's why we say recovery time reduces recovery time. And then it also reduces the number of days you stay in the hospital, hospitalization duration is what? Reduced. And then the best part of it is that the pain, nobody wants to go through pain. Pain is also what? Reduced with minimally invasive. And minimally invasive surgeries have been possible because of what? Endoscopes. Uses of endoscopes, diagnostic visualization to diagnose, just to see and see what is wrong with you. All right. Then surgical procedure. All right. Laparoscopic and then arthroscopy. All right. Biopsy and then therapeutic interventions. Okay. Biopsies to go in there and take sample to run some tests and what have you. Okay. Mean that they are going to take some part of your body, go and run cancer stuff, cancer related stuff. So biopsy or therapeutic or therapeutic means they give you a treatment. Okay, scope to over big like that. So they use is create a small hole and go in there with the help of scopes to do that. Salivary gland, stone extractions. So kidney, when you have stones in your kidney, they use the endoscopes to go in there, watch, and then crush those stones so that you can, the pain that you are going through will go out. You'll be relieved of that pain. So endoscopes are used in minimally invasive surgeries. Next slide. Let me see how long it is. If it is not that long, I'll take it. If it is long, then we go. So let me take this one then. Before we break take a 15 minutes break. Evolution of endoscope technology. How it started. Okay. The 1800s. Basic scopes for visualization was done in Germany. Okay. Then the 1800s. How many of us were born at that time?
None of us.
Not
You were
even my
born.
egg.
Shania, you were born, right?
No.
Professor, not even my egg.
Oh, okay. I see. I don't think anybody on this platform was born at that time. Maybe not even maybe our parents.
I was born.
Okay, good. Then we have a Methuselah on post World War II evolutions or upgrades. Because of that, because of the advancement, because of the increase of knowledge, they develop better ones, which function more than the 1800s ones that uses fiber optic cables and lightning. Okay, and then the 20th century introduction of flexible endoscopes. So this endoscope, the idea of endoscope was not today, but they have been upgrading them. And I'm sure 100 years from now, when none of us here will be around, some people will have a different conversation about endoscopes. All right. Modern day technology, in terms of in regards to our endoscopes, we have fiber optics, enlightening, emitting LEDs from them. So the fiber optics, they use light passes through a cable and helps to visualize or for the procedure, whatever they are using it. They will have high definition video endoscopes, high definition. So we have scopes that will be able to give you quality picture of what is going on in the human being's internal organs. It's very interesting to go to walk into the operating room and see somebody on the bed so helpless, and then they are working on him or her. All right. and then we are able to entertain our eyes by watching the monitor with these video scopes doing a wonderful job. So high definition video scopes for real life or real time viewing. Yeah. Then miniaturized instruments, allowing complex surgeries without large incisions. So you can create a hole, puncture a hole, pass through an endoscope in it, and you can also pass other tiny instrument in the endoscope to do some manipulation in the internal organs of what? Human beings. So it's very, very, it looks abstract. Right now that we are speaking, you are not seeing the scope, but I am able to say because I have worked with it, but I can promise you that when you study hard and you pass the test, you will definitely get to see what I am talking about. No matter how small your hospital will be, you will get to see some of them. And you remember this conversation we are having today. I think it is appropriate for us to stop here and then take a break when for 15 minutes and we come back. Let me just say that it's 4:20 now. We'll come back 4:35, right? Director. All right. Director, are you with us? No, we are taking a break. All right, so we'll stay here. Let's take a
Yes,
break and then we come back at 4:35. Okay?
Ní magana.
All right.
all right, John. Thank you.
Okay. Thank you, Shania. All right. So we are looking at light and image transmission in endoscopes. So endoscopes, two things happen. Light is transmitted and image is what? Produced or transmitted. So the light makes it easier for the surgeon to see what is going on in the body. And then the image, the scope, the lenses that are there will produce the image that is on the monitor that you can see or visualize. All right. So light transmission provides illumination in the body, and then the image allows the surgeon to see the internal structures of the body. The light comes as a result of fiber optics. The cable carries the optics carry the light into the endoscope. Okay, and then the LED emits direct light when voltage is what? Applied. So basically, the lighting tech system, the fibers in the wires or the cord will produce a light that will enable the surgeon to see in there. Now, when the light is poor, when the cable is broken and you cannot see or is not able to produce a bright light, what happens? The surgeon finds it difficult to see. So poor lighting leads to unclear images and inaccurate diagnosis. You are not able to see because the cable is broken. The fibers are broken. So this disconnected light, the light is poor. Or the tip of there's a chip on the tip of the light cord where it is connected to the fiber optic, it can bring about that. Or the lens of the fiber optic is broken, it can bring about poor imaging or quality of the image that you see. Damaged fiber optic or lead failure can compromise the procedure. We have seen that. Next slide, please. This today I'm gonna go solo. You just listen to me, guys, and then I'm gonna go solo. I'm not gonna disturb anybody. So everybody feel free. I'm not gonna call you to read. Leave it to me. But if you have a question, pause me and then ask. Okay, classification of endoscope. We have flexible endoscopes. They are classified flexible endoscopes and the image and then we have rigid endoscopes, flexible and what rigid. And in some cases, you also can find semi-rigid. Okay, semi-rigid. Some semi-rigid endoscopes. So flexible endoscopes, by the name, it means that they are easy to bend. You can bend them any way, anyhow. But because it has fibers or lenses in there, you cannot bend it and squeeze it like as if you mean to break it. Then that you are just trying to damage it. So flexible, it can be coiled around it. All right. So and then the rigid, as the word rigid means, is stiff. It's not. It cannot be. You cannot bend. You bend it, you break it. Do not bend. And made of what? Metal tubes. Okay. Used when straight line access to the surgical site is what? Available. So their usages are different. So the flexibles are used differently from the rigid or semi-rigid. Okay. Common applications: laparoscopic. We have the abdominal one surgeries. We have arthroscopy. We have joint surgery. That is, arthroscopy has to do with ortho. Then cystoscopy has to do with your bladder. Okay, every human being has bladder, and please make sure you don't damage your bladder by keeping the place full for a very long time. You can even pass out. All right. So we have flexible endoscope, we have rigid endoscopes. And then next slide. Okay. And we have the semi-rigid endoscopes. We have semi-rigid endoscopes. So the picture you see at the top with the white background is the anatomy of what? Rigid scopes. So those are the parts that you have. You have the tip, the lens, we have the connecting part where the light comes in. All right. And then we have where the camera will load on to be able to see on the monitor. All right. If any of these parts, if there's a dent on the shaft for the tip to where the light source will come in, the scope is done. All right. So if you drop it, finito. If you step on it, capiche, finish. All right. So semi-rigid endoscopes. Semi-rigid means that they are a bit flexible and they are rigid as well. That's mean by semi-rigid. So slightly bendable. All right. Slightly bendable. They are used for radiology procedures, like the one down the figure 11.32 is a semi-rigid one. It's a semi-rigid one. Okay. The one at the top is they are rigid scopes. You can't bend them. But with the semi-rigid one, they are skinny. You can bend them. The two protruding parts closer to the black round circle, they are channels. No, not that one. The down one, the director. Yeah, the two channels. No, not that. That's the light source. Yes, this one, the one that the director is pointing are channels. Okay, water goes there, can go there through it, or they can pass through a grasper through that to grab anything that they see in there. All right, so slightly bendable, and then we have the flexible, as we said. That one you can maneuver, you can flip it any way you like. They are highly maneuverable. They are highly maneuverable. And then for them, for flexible, we have a variety of them. We have the gastroscope, we have the bronchoscope, we have the colongoscope. All right, gastroscope. Gastroscope goes into your gastro region. Bronchoscope, as the name applies. The colongoscope, the intestines, the large intestines. Okay, that's where it goes. It goes from your behind. Okay, all right, all of that. So that is why when you are treating them, you have to observe standard protocol. You have to gown down so that you don't carry somebody's stuff to your house and infect your people. All right, you don't know what is in somebody's bronchitis, what is there, you don't know what is going in somebody's chest, you don't know. So please be mindful when you do it. And then some of them come with fluid in there, because when they go to examine, fluid stays in there. It's supposed to be flushed in the oral, but just as some of our colleagues cut corners, oral also staff also cut corners. Instead of flushing it with some solution to take out excess of the fluid that stayed there, they leave in the packet. They say the dirty people, those who will deal with dirty stuff are waiting for us. So let's take it there. All right. So careful, delicate, and prone to what? Damage. So because it's flexible, okay, it can easily be what? Damage. Endoscopic imaging classification. We have non-video scopes, endoscopes, and then we have the video endoscopes. The video endoscopes display images on a monitor via fiber, optic, or digital camera chips. Okay, the non-video one, the surgeon looks through an eye piece and directly sees what he wants. But with the video one, yes, you see movement on your monitor and what have you. All right. So those are so we have the endoscope, we have the flexible, we have the rigid, and we have the semi-rigid. Okay. So remember that endoscope, rigid, semi-rigid, and flexible. Any questions so far before we go to the next slide? All right, great. Operative versus non-operative endoscopes. Early endoscopes were non-operative. Early endoscopes were non-operative. Okay, meaning they were used only for viewing. So those ones that were created in the 1800, they were just used to visualize and then go. Modern day ones, they have working channels. That's what the director was using the cursor to show us, lumens that they can pass through liquid, they can pass liquid through it, or grass through to be able to grab something in there. Used for biopsies, tissue removal, and other procedures. So the operative ones, yes. If they see something is growing in your internal organs that needs to be removed, they use the endoscope with a grasper to remove it. Okay. Enable minimally invasive surgeries like laparoscopic and arthroscopy. Yes, a small incision to be able to get access or to gain access to whatever they want to do. Okay, so operative and non-operative. Okay, move on. Next slide. All right, smaller and more advanced instruments allow endoscope heart procedures. Smaller and more advanced allow endoscopic heart procedures without opening the chest. Before, if they were doing heart surgery, is a bunch of trays, huge, big retractors here and there, because they have to cut open your chest and then use all this book water and those things to open your chest in place for hours whilst the surgeon is working on it. I don't. It's like a butcher house, but today it is not like that. You go in, they create a very small hole, and then they can go in and do a whole lot. Okay. Then pituitary surgeries through the sinus cavity. Yes. All right. Salivary gland stone removal without incision. Okay. Gastrointestinal and lung biopsies without major surgeries. All these things have been made possible because of what? Advancement of what? Endoscope. It makes it easier for them to go without having to bother and make big openings. Selection of endoscope based on surgical needs. So rigid, we use rigid ones for laparoscopic and arthroscopic cases. And even cysto cases too. Yes. And then some of the semi-rigid can also be used for cysto cases. All right. And then the semi-rigid, we have the urology, which is also cysto case. All right. You can find cysto in there. And then the rigid ones, we can find it under the ENT or the ear, nose, and what? Throat. So depending on the surgery, there's a scope that they will need. Laparoscopic is rigid, ENT are rigid, urology is semi-rigid and flexible as well. Flexible, we also have cystoscope over there. You also have things that will go inside your organs, your reproductive organs, to see what is going on. All right. If you have urinary tract infection, it is only the flexible that can go inside your reproductive organ to visualize and see if you need surgery or you need more testing for them to take biopsies to take care of your situation for you. So the need of the scope arises as a result of what it is going to be used for. Endoscopes act as surgeon's eyes in the body. Cannot emphasize that. So it helps them to see a bigger picture of what is going on in your system. Improper handling can cause significant damage, leading to costly repairs and procedural delays and even replacement. Yes. So if you don't handle it with care, you damage it. Either you use the wrong sterilization method to damage it, or you allow fluid to invade it to damage it. And the fluid invasion can happen in the OR, it can happen in CSPD, or you put heavy items on it to break the fiber, to break the lenses. All of that will damage the scope. Next slide. Okay. So challenges in handling and maintaining endoscopes. Frequent handling. Okay, up to eight or more people per cycle increases the risk of what? Damage. So if a lot of people will have to handle the scope, the chances is that one of us will what? Cut corners or will do the wrong thing. But if it is handled by few people or the same person all the time, the chance is that it will not result in any damage. And if it does, it is easier to investigate. If it goes through a lot of people, everybody will start to shift blame. Try to say, oh, it wasn't me, it was so and so, and a whole bunch of confusion going on. Poorly maintained endoscopes result in blurry or distorted images. Yes. If you don't clean it well, it will come out with biobedding at the tip. It will not be able to visualize or produce a quality image. All right. When your mirror is tinted with all manner of things, you can't see your face well. So you have to clean the mirror to see your face well. Same thing applies to endoscopes too. Procedure delays, potential harm to the patient. Yes. Okay. Common damage risk, scratches or cracks on the lenses. Scratches. Because the surgeons go in with instrument like flexible graspers to take biopsies, and in the process they can damage the lenses. The semi-rigid ones, the doctors can bend it to see something that is very, very hidden, and in that case they can also damage it. All right, could be broken. And fluid invasion is a common one too. So if you soak it for damage it, okay. All right. So it says automated washing of rigid endoscopes. Newly technology enables automated washing of non-operative endoscopes. Yes. So because of the advancement of endoscopes, Some manufacturers make it possible for it to be pushed through washer. You can pass it through the washer. If the IFC says so, why not? That will lessen your burden. So do it. But most places, even when it does say so, for the purpose of to prolong the lifespan, they do it manually. So yes, you get to see that when you are on the floor. Check manufacturer's IFU for that, mentioned already. Benefit of automated washing, consistent cleaning. Definitely you get it right because it's a machine that is doing it. Okay, reduces manual labor, which I mentioned. Everybody will want to do less work, right? So it's important. If you are lucky to work in a facility where that is done, good for you. But in most cases, we don't have this. And then important notes. Ultrasonic cleaning cycle must not be used in automated washing as they can damage residual endoscopes. So please do not put your scopes in the ultrasonic, okay? Ultrasonic machine. Do not put your scopes in there. It can damage the fiber or the lens of the scope. It uses ultrasonic machines uses a process called cavitation to do the cleaning, and that can damage the lens of the scope. So please, it creates some bubbles and that can destroy that whilst in the process. Next slide. All right, next slide. Again, best practices in doing that. IFU, handle with care, don't drop it, don't burn it, inspect for cracks, loose parts, biobedding, and then select proper cleaning materials to do that, and then use the right sterilization method so that it will not what? Destroy or damage it, okay? And then also store it in the right place that it is supposed to go. Most of them are endoscopes that are some of them use low temperature sterilization, you don't have a problem. But those that go through or use high level disinfectant, which shall be seen shortly, their storage system is different. The one that use high level disinfectant, it means it is not sterile, but they disinfect it to be able to use. That is what the IFU says. You have to disinfect it. But when it comes to disinfecting of scopes, we will have to pay attention to certain rules. When we get there, we'll talk about it. Those ones are stored in cabinets. That's why it's talking about it as designated cabinets or trays to prevent accidental damage. All right. So best practices, we have seen it several times under those powered surgical instruments. The same thing applies here. IFU is always number one on the list. And we also have others that go through automated endoscopic reprocessor. Automated endoscopic reprocessor is a machine that you connect all the channels of the scopes to, and then the machine will do the work. But before the machine does the work, you will have to do the manual part before the machine will do the remaining. So it means that even though machine would help, you have your part to play. And those parts the part that you have to play, you have to do the best of your ability. Next slide. Okay, so we saying it helps minimal surgery procedures with best outcomes. You have to handle it with what? Care, right? And like I said, you have to select the right sterilization method. And you can get that without sweat by looking at the IFU. Okay, so when you get the IFU, it's a book. Just go to how it is cleaned. That's where you can read and see the chemicals that is needed, what you need to do, how it is cleaned. Then go to the page or you go to the content, look for how it is cleaned, then go there. Then look at how it is sterilized. Then you go look at the content or table contents, then go to the page, read the sterilization method. If it is steam, it will tell you. If it is sterile, it will tell you. If it is high-level disinfectant, it will tell you. Don't waste your time reading, flipping page to page. You will spend the whole day before you get to what important information you need. Next slide. Rigid endoscopes. Rigid endoscopes. Rigid endoscopes, endoscopic instruments come in various shapes and sizes. Many contain lumens and require specialized cleaning techniques. Some instruments consist of multiple detachable parts. Laparoscopic of handles, blah, blah, blah. All right, I don't want to read all of that. That's why I say blah, blah, blah. All right, so different and semi-rigid what? Endoscopes are there. Some have what? Lumens, some do not. Okay, you see a lens and you still see a tiny hole that goes through it. So, for example, semi-rigid endoscope have two channels that director was using the cursor to show us. Those lumens needs to be what? Flash. Those lumens instrument pieces go in there. The challenge is that the design is you cannot dismantle it, so you have to use the appropriate brush to do that, or you have to flash it with a syringe. Whatever the IFU will tell you to do, maybe it will tell you to flash it 3 or 4 times. You do the same. Okay, but because of shortage of instrument, there's a likelihood that somebody, if they say flash it 3 times, you'll flash it 2. Okay, and get out of here. I just want to get out. Okay, so always follow the IFU. The challenge, it says some designs do not allow full dismantle, making it difficult to verify cleanness inside lumens. So you cannot dismantle some of them. Instrument with flash ports may retain debris if not properly flashed after each use. So you have to flash every one that has a channel. Flash it. If a brush can go through, use a brush. Or if the IFU says the manufacturer provided a brush, use the brush and then go through. Check the tip of the brush to see if there's any debris. If you don't have, flash it so that you don't leave any lint, any leftover of brushes in there, but because that can harm the patient. Then say hidden contamination risks. Soil can get trapped in lumens, hinges, and then cover spaces. We mentioned that. Debris under rotating components. So the parts of the endoscope that rotate, we have manipulating devices or levers, some mechanisms on the endoscopes that the surgeon regulates or either rotate or press down or press up, just like the foot paddle. Those ones that the surgeon uses his hand to do whilst his hand is bloody, all of those areas have to be properly inspected for biobending and cracks so that you can clean them to make them ready for what? Use. Next slide. All right, next slide. Okay, thank you. Operative endoscopes require specialized instruments. Operative endoscopes require specialized instrument for performing surgeries. Common instruments used with rigid and semi-rigid scopes include laparoscopic instrument. Laparoscopic instruments are instruments that we use for most of the time minimally invasive surgeries, and they are used alongside with semi-rigid scopes, and then sometimes and most of the time cameras. The scope has to be mounted to a camera, and then the camera will provide the image, and then the laparoscopic instrument is what will go in with the help of the scope and the camera to perform the job that it needs to be done. The laparoscopic instrument can be dismantled, can be disassembled. Okay, you have to break them into the various components so that you can thoroughly clean them. When we get there, I'm sure down the line we'll see those laparoscopic instruments. Sorry, slender and long instruments typically. That we are talking about laparoscopic instruments here. They are slender and long. They are very long, about we have some of them, the thickness could be 10 inches, some of them the thickness could be 5 inches. They have insulations, and then they have the pins, they have the handles. The handles has to match with the tape, and everything will be stated by the manufacturer. Okay, everything will be stated by the manufacturer. And then the count sheet that is built by the hospital or the facility will also tell you which handles goes with which instrument. So you don't just put it together because it is jumbled up. You also jumble up the whole thing. No, it has to be accounted for following the count sheet in front of you on your computer. Their design shaft resembles a pencil or rod. Yes. I hope that along the line we'll see them so that it doesn't look too abstract. But for now, we are talking from the abstract point. Their distal tip matches general surgical instrument of the same name. So you can have a laparoscopic, which is called an Alice. We can have a laparoscopic that is called Maryland, or in the form of a Kelly or a Mosquito. We call laparoscopic called Maryland. It's not the state of Maryland, but that's how it is called. You get to see it. It's curved. It is serrated. Okay. Then we have some laparoscopic ones. We have the tenaculum. Okay. You have the tenaculum. It's sharp. It's meant to punch out some holes where they need it. All right. They are all determined by the surgeon. You don't have control over what you should put in there. You go according to what you see. Next one. Electrosurgical laparoscopic instruments. So some of the surgeries, laparoscopic instruments have electrical parts that they connect electrical power to, that help it to work. Okay, they have the connecting part that they mount the connect cable that will allow electrical energy to be transmitted to that piece, that section, that will help it to be used. Okay, so you will see it as a pin. That pin is what is connected to the cord, and then the cord with the metal touching the electrical DC will produce energy or electrical energy into the instrument, and then the surgeon can work with it. Without it, it will not work. So it means that for that laparoscopic tray, you will always find a light cord in there. You will always find a light cord in the laparoscopic instrument set, because without it, some of the instruments will not work. So insulation covering the shaft protect the patient from intended electrical burns. So we will see that along the line, you need to test the insulation to make that there are no cuts, because if there are cuts, it's going to electrocute either the surgeon or the patient. You're going to burn the patient. All right, you don't want to do that. And if you're a patient, you don't want to go to surgery and get burnt. Failure of insulation can cause uncontrolled electrical leakage, leading to burns or organ damage. All right. And when they are using this laparoscopic instrument, you pass by, you smell that a human skin is burning. You are passing by, you smell that. Increased risk of infection and extended recovery time. Self-explanatory. So when the insulation is broken, you're going to cause burn, and that means that the patient will need more time to recover. All right, next slide. Okay, there we go. So on the picture on 1140, yes, those are the laparoscopic instruments. So this gentleman there is testing to see if there are breaks in the insulation. So that white device is the tester connected to another device. Yes, that is the tester is holding. So if there's a break, he's passing the tester through the shaft. If there's a break, you hear a sound. Okay. If it travels the whole length and you don't hear any sound, it means there's no break. Okay, that's how we test it. If there's no sound, it's no break. Same way, the handles there are also tested. They are tested differently, the same device, but this time he will take the white one and mount onto it something like a broom, and then he'll use the broom or a brush. Let me say it that way, a brush, because some of us don't know broom because we are born in a very powerful state of New York. We have not seen broom before, so but everybody has seen a brush. So some of them, for the handles, there's a brush that you mount to where this white one is. Take out the white one, mount the brush, and then use the brush to sweep the handles. If you hear any beeping, the handles are also have cracks. But if you don't hear beepings, they don't. But thank God, lately they have handles that do not have metals. They are just plastic. So you don't have to bother yourself. If you have laparoscopic instrument that the handles are just plastic, there's no metal inside, you're good to go. You don't have to test. You only have to test the insulation. Are we there? Are we okay?
Yeah.
Yeah.
All right, good. Hooks and spatulas. Hooks and spatulas. So these hooks, those are the tips. So the picture on your left is the hook. Director, the other one. The Kaiser should be, yes, that's the hook. In some, always call it L hook because it looks like an L. So we call it L hook. And then the other one on your right is the spatula. Right. So now these two items have channels in them. They have channels in them that needs to be what? Flash. And then the tip get used aggressively. So they come with some black, because it's connected to electricity or energy, it bends the blood or the tissues at the distal tip or those L hook or the spatula. So sometimes it comes, if the person at the content doesn't do a good job, it will come with all the bent substances on it. So if you are inspect that, brush it, and then also flash it. So if the person does not clean the tips, either the L hook or the spatula, it means that there's a high possibility the person did not flash the channels. So you have to get a syringe with water or alcohol and then flash it. You will be surprised to see what is going to come out. You'll be like, it didn't do a good job. All right. Okay. So always remember to look for this L and the L hook or the spatula. They have channels. Check the tips, flash the channels, and then make sure they are good to go. Okay. There are also these two items that we are seeing are also powered using what? Light. So they connect them to electricity. All right. Next slide. So you see that at the top, the picture with the white background, 11.35, they have been dismantled or disassembled. I don't know why I put dismantled. They have been disassembled. You see the handles, and then the instrument piece, the metal part that is in the middle, and then the extreme top is the insulation. Okay, so you test the insulation for cracks. You check the tips of the metal one, that is the middle, for biobedding, because the tip is where it's used. Then you check the handles for any cracks, any biobedding, any loose part. On the handle, that pin, you see, can you show them the pin? I want them to see where the electrical part is connected, the pin on the handle. No, at the top picture. Yep, the pin at the handle. Yep, come down a little bit. No, you got, yep, there. That is where the power or the cord is connected. Okay, that is where the cable is connected to, and then it does the work. All right, it does the work. On the top, data, show me the top one. The dot at yes, is a port. It's a hole. It's a channel. That is they close it to work it so that blood does not come out in this thing. So what it means that if it is used, there will be blood stuck in that tube. You need to flush it. And the running water, you need to sonic it so that cavitation will create that bubbles to implode and clean your tubings. All right. And then the rest of it is the other parts is what we have there at the bottom, figure 11.42. We have the insulated handle and we have the metal handle. You see the metal handle? Those ones, you don't have any electrical connection. The one in the middle, the handle. And then we have the needle holders also. Those ones, they do not use electrical power, but the insulated ones and what have you, they use electrical power. But the fact that they are metal and they don't use electrical power doesn't mean we shouldn't inspect for what? Cracks, biobedy. You still have to inspect them. Next slide. So cleaning and assembly of laparoscopic instrument. So for cleaning purposes, they have to be disassembled. They have to come apart. They have to come apart. Don't say that because you have not seen blood on any of them means that, oh no, this one was not used. Dismantle, why am I using the word dismantle? Disassemble every single one of them in the tray. Okay. So flash every one of them. And if you are dismantling them, that is when you know which one of them was used. As soon as you dismantle, you pull out the metal pin that was inside the insulated device, you will see blood on the metal pin. That means that one was used. So you pay attention more. The one that you disassemble and you will not see any blood on the pin or the metal part, it means that it was not used. But all of them would still need to be clean and washed properly. All right. So you assemble them before flashing and brush the hooks, the spatula, and all the needle holders that are in there before you take them through the wash. And then you can also, you have brushes that you can pass through them, or you can put them under running water so that you can get all the blood out. But the best place to do them together right after flashing and brushing them is also putting them through the sonic. Because of the cavitation, it will clear everything that is in those channels. All right. Inspect, the last point is inspect for cleanliness. So dark colored surfaces can make the contamination hard to detect. Yes. So sometimes you don't see, because the background is black, it's difficult to notice whether there's blood in there, especially so if it's dry blood. So always make sure that you give no room for any error. Treat all of them as dirty when they come to decontaminate. Next slide. Today is a solo day. It's for me. All right. So just listen. Pause me if you need to ask questions, guys. Don't hesitate to do that. Assembly and storage. So you have, once you dismantle the instrument, when you are going to assemble it, you have to. Hey, did I say dismantle? Today is a terrible day. So once you disassemble the instruments to clean and decontaminate, if you are putting it together, you have to put the three pieces together. Because the surgeon does not, some of the surgeons do not even know how to put the laparoscopic instruments together. Trust me. That is why your job is so important. Without you, the doctor's certificate is valueless. So when it comes to that, be bold, and that is where you show your crafty powers, if I may put it that way. you show the sergeant that you know what you are doing. So they don't know how to do that. So you have to assemble the disassembled pieces before you sterilize. If not, trust me, you'll get called to your manager's office because the surgeon will be frustrated. Even the techs and the nurses don't know how to put them together. All right. Sometimes you put them together and they are not properly assembled. In the course of transportation, some of them come apart. And if the surgeon needs to do it, they would have to call you, the manager, to the room, and you will have to be directing them how to do it. You can't touch it either because you are not scrubbed in. You are not sanitized. If I say scrubbed in, you are not sanitized to touch it. So you have to be directing you, do this way with a big accent like me. They'll be like, okay, I don't even understand what he's talking about. So please assemble laparoscopic instruments before you sterilize them because the surgeons don't have the ability, they don't have the know-how to do that. It is you who have to do it. And each of the handles have to go with a particular laparoscopic instrument. You don't just put any handle anyhow. And that you can get help from the count sheet. The count sheet will say use insulated handle. If you say use insulated handle, you go and use a metal handle, then it means that you are not able to read. And one of the requirements of being able or being hired is being able to read and write. If you cannot read and write, this job is not good for you because you kill somebody. All right. So assemble this assembled instrument from decontamination. It will always, laparoscopic instrument will always come disassembled. If it comes assembled, it means that the person in decontamination failed to do his or her job. So if you are in a clean site and it comes assembled, just take it back to the person to do it properly. Next slide. Sterilization. Follow IFU. Whether it's low temperature or high temperature. But most of the laparoscopic instrument sets are high temperature sterilization. Okay, most laparoscopic are high temperature, which is steam. Okay, but all the same, you get the IFU, and you are not going to be the person inventing or creating the sterilization method. Before you get there, people are already doing the job. They'll just teach you what to do. All right, just pay attention to what they are teaching you on the job. All right, next slide. All right, these are the takeaways. Automated washing improves efficiency, but must exclude ultrasonic cycles for rigid endoscopes. Yes, we mentioned that because the lens will break. Lumens, hinges, and hidden spaces require extra attention to prevent contamination. Laparoscopic instruments must be intact to prevent electrical injuries to patients and surgeons. Okay. Manual pre-cleaning and proper assembly ensure instrument functionality. Then, proper storage and sterilization method extend the lifespan of the complex instrument that we have been talking about. Next slide. Those are the stuff that you have to. Now, let's come to the robotic endoscope. Now, it is endoscope. It's going inside your body. Now, it's not controlled by the surgeon, but it is controlled by a machine with the press of some buttons. Like how many of you have been playing video games? I don't know how to play, but I've seen my son play a lot. You didn't see the video game, the way they play with pressing the button here, left, right. They have two buttons, two controlling device, one on the right, one on the left. They control both of them at the same time to win game. The same thing. That's how robotic machines work. So these robotic machines, you cannot use robotic instrument without the machine. It will not work. Okay, you can go and get a cable box from which are Verizon, and you don't have a monitor. You won't see anything. You can connect it anyhow you won't see anything because one piece is missing. So laparoscopic or robotic instrument goes with the machine that helps it to work. So robotic surgeries are gaining popularity across multiple surgical specialties. Most of now it used to be abdominal. Now you can get thoracic cases having robotic going in there. Okay, maybe along the line we'll see some of what we are talking about. They connect with electricity. They use them, and then they have a lifespan of uses. On them they have a certain mechanism that every use it feels that spot is a white dot. It fills gradually, and when that white dot turns red, you have to throw that robotic away. It means it has outlived its usefulness. It's no more good. It will not fire. If you say it will not fire, it means that if they press the button for it to work, it will say, I'm not working today. All right. So be on the lookout where you're processing robotic instruments. They are using electricity. They have a certain number of uses after which they become dead. Okay, so they are always being replaced. But how do we clean and take care of them? So both small, they are used in both small incisions. They control by the machine, and then some screen that the doctor is watching and then doing the work in there. Just as if you see somebody playing video game, that's how robotic works. Physically, that's it. All right. Complexity of robotic instrument, heavier than laparoscopic. Yes, they come in the form of laparoscopic instrument. Okay, but they are heavier. They are heavy. They are longer. They are heavier. Okay, their tips are a bit complex than the laparoscopic ones. They contain mechanical and electrical components housed in the proximal end. Yes, the part that connects to the machine that is controlled by the surgeon, it comes with electrical part components, and you have to pay attention. Okay. More challenging to clean. Yes, definitely more challenging to clean. All right. Okay. Than laparoscopic instrument due to lack of detachable parts. You cannot detach it. You cannot disassemble robotic. No, you cannot disassemble it. Then rotating distal ends. They rotate. You can wind it. All right. Okay. They rotate. Okay. Multiple internal channels. I think every robotic arm has 2 ports, if I'm not mistaken. Yeah, every robotic arm has 2 ports. I've not seen one that has 1 port. So you have to flash both ports. Both channels has to be flashed. And then if you are lucky and you have a facility that has a sonic that cleans and disinfects or clean the robotic arms, then you're good to go. The work is reduced. But if you don't have, everything that we are talking about has to be done manual. It has to be done manual. All right. Next slide. Yes. I don't know how, if you look at the top picture is a robotic arm basket. Yes, the one the director is showing you. So the proximal end is the white stuff that you see on the edges. So in this basket, there are 8 robotic arms, 4 on the left, 4 on the right. In the very top basket is what I'm talking about. So you have 4 robotic arms, 8 robotic arms, 4 on the left, 4 on the right. The picture underneath is the machine, the sonic that cleans these robotic arms. So you soak them, you get the tips clean of debris or biobedding, and then you connect them in the middle machine to clean and disinfect. In some cases, once the middle machine does its job, it's good to go. All that you need to do is assemble it, get it sterilized. In other places, they will tell you beyond the sonic machine, robotic sonic machine doing its job, you still have to pass it through the wash. That's why you have the third picture there. So either the third picture is, I'm not able to see that picture too well. I don't know whether the person is working by the sink. Is it working by the sink? My eyes are not too good. Can somebody help me out? The bottom picture.
No, there's nobody standing
right
next to it.
explanation.
There's nobody there.
There's nobody there, right? Okay. So
Yeah.
it means that, so one, the top basket is the robotic arms. The middle machine is what cleans it. Again, you connect it, the IFU will show you, and you get in-service on it. Most of the robotic arms most of the time are done by the robotic sonic machine. But because it's a machine, it will break down. And when it breaks down, surgeries must continue. They are not going to hold surgeries. They are not going to cancel cases. Surgery will continue. So you have to do it using the improvised way, the alternative stated by the IFU. So in this case, you manually clean it, flush all the ports, clean the tips, and then pass it through the washer. That's why you have the third picture, which is at the bottom. All right. Is everybody okay?
Yeah.
Yes.
All right. Awesome. Awesome. Next slide.
Yes.
Next slide. That next slide. All right. So now we come to arthroscopy ward instruments. So you see the picture at the top, 1146. They are the instruments. Okay. We have the scope. You see the scope at the top. The very top item is the scope. That is this rigid scope that they use to see. All right. These instruments are small. Some of them are graspers. Some of them are trochus, or what have you. But the biggest one I want you to look at, the main one I want to look at is figure 11.47. This is what we call a shaver. You remember we mentioned shaver? This is a shaver. This one, the cord is connected, the red part is connected to a power source, and then the blue part is what the doctor holds and then manipulates. Director, can you point to the port channel for me? Yeah, no, down. The next, at the blue section, there's a white piece by yeah. Oh, you almost got it. A little bit right. Go further right. Yes, stay there. Everybody see where the director's cursor is? That has a channel that needs to be brushed because debris stays there. The piece that is shaving is loaded over there. Okay, it is loaded over there, and then it comes at the distal or the tip. And now getting to the silver end, that go back to the picture. I just want to give them what they need to watch out. Then we can go to the next slide. Getting to the round silver piece on the same picture. Yes, those you see before the cursor, you see 2 dots. Before where the cursor is, you see those 2 dots. Those 2 dots are buttons. That is what the surgeon is regulating. So those ones also come dirty. You have to what? clean them. This piece is hand washed because the IFU does not allow it to go through the washer. So you have to manually clean it. And you have to use brittle brush, not metal brush, to brush some of the delicate portions and flash the parts that I showed you where they load the shaver to do its work. Okay, so when you get arthroscopy instrument, you have to follow the protocol. It will come with scopes and other pieces. Camera will be there. There will be a remote control will be there. They will all specify how they are cleaned. And they are most arthroscopy cases are used for most arthroscopy instruments are used for joints, where we have joints. Okay, so they use it for shoulder cases, they use it for knee. So you always hear knee arthroscopy or shoulder arthroscopy. So if it's shoulder arthroscopy, it means that the region where they'll be working is on the shoulder. If it's a knee arthroscopy, they'll be working on the knee. Okay, next slide. Now, fiber optic endoscopes. So I don't know why we are getting there, but they can be bent. Ability to bend, we saw that. For diagnosis, for visual, for biopsy, maybe for emphasis, that's why they are repeating, giving you additional information. They're used for minimally invasive surgery. So another, the acronym for minimally invasive surgery is MIS. If you hear MIS, it means minimally invasive. Okay, small hole, enter, do the work, get out. Okay, it's only a bit complex dealing with this instrument. You see the tip, the picture 11.9, sorry, 0.49, the distal end of a flexible endoscope. So the 3 dots or 4 are the eyes, are their cameras or lenses that provide the pictures or visuals that they see on the monitor. And they see that there's a big dot. That is a channel. They can pass biopsy grasper there to grab a biopsy or to manipulate some organs or for therapeutic treatment. Okay, so endoscopes, flexible endoscopes, that is how the tip looks like. Some of them, this one, I think it was magnified several times. That's why we are able to see all this. If we get, or this might look like either it's a gastroscope or a colongoscope, one of them. I'm not too sure. It looks like it looks like more of a gastroscope, which goes through your mouth. The colongoscope goes through your behind. So remember that gastroscope goes through your mouth, colongoscope goes through your behind. Okay, know that. All right, and you can imagine both of them will come dirty, especially the one from the behind. Okay, so when you are treating it, gown yourself well and then don't cut corners. Right. Next slide. We are just taking the salient points and then we go because we have a lot more to cover. Components of flexible endoscopes. Hand assembly, handle assembly, or hand assembly. So they have control knobs, because without the control knobs, it will not work. Okay, because they are operative instrument. You need to do something for it to work. If you just load it and think it will work, it won't work. You have to direct it. Okay, you have to direct it to get it to work. They have a light source. With that light source, you won't see anything. Okay, the shaft is embedded with lens, so you don't have to put heavy instrument on them. Okay. Unfortunately, unlike semi-rigid and rigid scopes, you can look through, you can raise it and look through to see whether you see light. And you always have to point to a light to see whether you can see the light. Unlike the endoscopes, flexible endoscopes, you cannot see the light. Is unless you mount it onto a device or a machine, that is where the light will be produced for you to see the light. But under the semi-rigid and rigid one, you can just raise it and you can see through that whether it is clear, it is not clear. Unlike flexible, you cannot guarantee it is clear and it's not, unless you plug it and point it to something before you can say, hey, the monitor looks blurry, therefore the scope is not good. But if you overbend it, you break the fiber optics or you break the lenses. If you put heavy stuff on it, you break it too. So they are treated with the utmost care that we need. They are treated like eggs because they are very expensive. All right, next slide. Director, next slide. Okay. So video versus fiber optic. Video versus fiber optics. So fiber optic endoscopes capture image via lens system at the distal tip. Image travels through fiber optic bundles to the eyepiece. These fiber optic ones, you need a camera to do that. Okay. You have the rigid scope, you mount a camera on it, then you put a light source. Unfortunately, the picture we saw is way back. I can't get the director to put it back on. But remember that fiber optic endoscopes, you will have the camera mounted at the lens head or this the semi-rigid head, and then the light source with the camera will produce the image. With the video endoscope, it requires electrical power source and a video system. So the device itself connects into a machine. The machine is powered, and then from the machine, the monitor gives the image. That's what we call it video. Okay, video. You watch it, you see moving parts. You see the movement. If the doctor is moving, is manipulating, is lifting something, you will see everything. You see the internal organs of a human being on the monitor. It's so mind-boggling, but you get to see that when you begin to work. All right. How do we treat that? Whether fiber optic or video scope, avoid sharp bends. Don't bend it. I have had surgeons take pictures and send it to me complaining of how technicians have put together flexible scopes. I still have them. And you can see that the surgeon was right, because what the technician did is questionable. It does not show professionalism, and then it's about to break costs, the hospital to incur some cost. Okay. So avoid sharp bends in the flexible shaft or umbilical cable, as they can cause damage. We have seen that several times. Okay, they're just giving us hey, we can say this 30, I don't know, 36 inches. Your esophagus, your esophagus is what this esophagus gastroduodenal. How can I even say that? That's what do you want to kill me this evening? So that is just esophagoscopy that we are talking about. It is a scope that goes into your esophagus. All right, just as we have one that goes into your bronchitis. All right, then the colongoscope is about, it says 60 inches long. Okay, 60 inches long. And the colongoscope is the one that goes through your behind. Okay, it's long. because you have to it goes through your intestines, both the large intestines, to see whatever is going on. So it has to be what? Long. Okay. Esophagus is just about half of the colongoscope. All right. Next slide. All right. Operative versus diagnostic. All right. Flexible endoscopes. So diagnosis, it means to diagnose. It's not for treatment. It's just to diagnose, to look and say, oh, you are suffering from this. All right. So those cases, those surgeries are quick. 15, 20 minutes is done. They just watch and take biopsy, go and run tests. That's it. Visualize and diagnosis. Operative means they want to cure something. All right. They've seen the run test. Now they want to take care of the problem. So include a working channel, additional channels for suctioning, irrigation, and what? Inflations. Expanding the organ for better what? Visualization. So with the operative endoscopes, yes, they want to use it for treatment. So it has all manner of channels that they use devices to pass through to give you the treatment that you need. Next slide. Sorry, guys, I had to get something quick. Protective caps for flexible endoscopes. So the ports that I talked about, they have caps that come with it. Okay. They have caps that come with it, either to stop fluid during the process of the surgery, or they open up the channel for sterilization to take place so that the sterilant can what? Sterilize the portion that will go into the patient. So caps are there for various reasons. Okay. We have water caps, we have venting what? Caps. The venting caps is to to open up the scopes to sterilization what? Process. If the scope is closed and you put it inside the sterile machine, you are about to what? Destroy it. So we have a venting cap. When you get there, you will see it, and maybe during the course of this conversation, we must see the picture somewhere along the line. So we have water cap that is used when the device is being used in the OR. And then we have the venting cap, which we use when we as technicians are assembling it for sterilization. Because with that, the venting cap, it means that the scope is not open for the chemical that is supposed to sterilize it to go into the channel. All right. But remember that when you are cleaning it at decontam, you must not put the cap on, because when you put the cap on, you have opened the channels for water to go in. So we don't use the cap in decontam, but we use the cap when we are assembling. All of that information will better serve you when you are on the job. So venting caps must never be used when the scope is exposed to fluid. Exactly what I said. Because when you use the venting cap, you're exposing the scope to what? Damage. It's like not wearing a mask and standing in front of somebody who has COVID and say, cough for me to see. Next slide. Types of endoscopes and their uses. Bronchoscope. So it examines the tracheobronchial tree. You see that when we started, we saw there's some branch, some tree-like this thing. We have my science, my biology is gone. I can't remember those two branches. Can Is there any biology student on the platform that will help us? Those two branches that go to left and right, I don't know. I can't remember it. So bronchoscope. So you get to see it, bronchoscope. Okay, just it's something that goes into your internal organs or the body. All right, for diagnostics, for removal of foreign body or tumors and what have you. Okay, gastroscope or esophagoscope. Yes, esophagoscope. Esophagoscope or gastroscope. All goes pass through your throat. These two pass through your throat. Okay, bronchoscope too, same thing. Pass through your mouth into your throat, and then it's taken to where it's supposed to go and perform its function. All right. Colongoscope or sigmoidoscope, behind. I remember there was a question about this sigmoidoscope. What is used for visualization of large intestines is sigmoidoscope. The answer was sigmoidoscope. All right. So things have changed. I can promise you that. But this was a question that I saw in my test, in my final exam that I was taking for the certification. The cystoscope or ureteroscope. Urethra, bladder, kidney. So these ones go into your urinary tract. It goes into your bladder. It goes into your urethra to see whatever is going on. They use it for both diagnosis and for both therapeutic. All right. Treatment and also taking samples for further testing. Then we have rhinolaryngoscopy. Rhino, your nose. Used for nasal, sinus, and then throat treatment. Okay. So we are the ones that also goes through your nose to see what is going on in your head or your nose cavity and what have you, to see if you're complaining of your pain in the nose and what they need to go in there and see what is causing them. Next slide. Cleaning of this. Some professional bodies, the manufacturer will give his way of cleaning it using the appropriate brush, using the right detergent, the right chemical, time of soaking, to give you how many minutes you have to soak it before you start manually treating it. But as this instrument is used over time, those who are using it and then those who have manufactured it and agencies that regulate this medical instrument and making sure that patients get the best out of when they go on the table, they also make some recommendations. That's why you see all these AMI, Cigna, and CDC all in there. So because it goes into your body, and some of them are not sterilized, they are only highly disinfected. It's just like using your wipes to wipe on top of your table. It's not, you cannot guarantee that it has touched every surface. So because of that, flexible endoscopes which deal with high-level disinfectant always have people coming back with infections of some sort. So you see the CDC coming in, you see the FDA coming in, you see some professional bodies making some suggestions to make sure that things are done right. That's why you see Centers for Disease Control having a say, Society for Gastroenterology, nurses and associates. These are nurses who deal with gastro cases. They just deal with gastroenterology cases or surgeries. So they can make a recommendation that let us deal with the scope this way, that way. Association for the Advancement of Medical Instrumentation, ST91 standards. Then hospital-specific protocols. Hospital-specific protocols means that infection control will make some recommendations that if you have a flexible endoscope, this is the way to go. Because when Joint Commission comes, infection control or before even Joint Commission comes, Infection Control will prep your department and let you know that in case the commissioner asks you this question, this is the right answer. If you go and say something different, it will be captured in the report and it's going to be captured with your name. Because before they ask you the question, they always ask you of your name. So the report will see your name. If you provided a wrong answer, everybody, all the big shot will see your name there. So personal protective equipment, you need to wear this personal protective equipment to be able to handle these scopes with what? Care. Because they come dirty, either through the throat or through your behind. It comes dirty. So you need to protect yourself and your family. And the PPE is there: gown, gloves, facial shield, mask, shoe covers, and hair covering. And when you get home, when you go to work and you get home and you work in decontent, please don't hug anybody. Go take a good shower before you hug somebody in the house. Next slide. Key consideration for endoscope cleaning. So manufacturer, IFU, chemical, brush, all the appropriate things. Do that. Avoid abrasive materials. Use soft, lint-free sponges and brushes. So in decontent, we have two kinds of brushes: the brittle ones and then the metal. The one that look like our toothbrushes that we use. We have the one that have metal, and then we have the one that have nylon or brittle. So use the brittle ones for things like this. If you use the metal one, you are just as causing harm than good. Your intent is good, but the act is bad. Intent is to clean, but the act of cleaning is bad. That's what I mean. So effective cleaning is crucial to remove organic debris, prevent microorganisms buildup, and proper penetration of what? Germicides. Okay. If you want to do it, you remove the debris. That's why point of use is done. So when the endoscopes are used in the OR, they're supposed to have some sponges that they wipe the shaft, the tip that went into the patient, which is bloody. They're supposed to wash it, so to wipe it with a sponge soaked with a detergent so that it will remove all those debris. But they don't do it. I can promise you that. They don't do it. They feel that it is somebody's job in CSPD called decontent person. He will take care of it. Don't worry about it. When the case is over, everybody will just want to pack it and go and give it to the decontent person. All right. So that's why when it comes there, you have to cross your T's and dot your I's so that you are safe, your family is safe, your colleagues are safe. All right. Next slide. Basic steps for reprocessing flexible endoscopes. So one, pre-cleaning. So you have to wipe. That wiping has to be done in the OR before it gets there. Then you have to do what we call leak tests. When you leak, you have to leak test it to make sure that there are no cracks. It's not leaking. When it's leaking, what happens? You are going to burn the patient. Okay? You are going to burn the patient. So you leak test it to make sure that there are no perforations on the endoscope. And then when you do the leak test, the testing device will be there. When you leak test it and it fails, you still have to go ahead and clean it, even though it failed. But it has to be communicated to the clean side when you are in decontent that the scope failed a leak test, therefore it should not be processed to be used the next time. So if leak test is very, very important, and the Joint Commission, they have been asking that. If they come to meet you in decontent, it's a Joint Commission survey, and you are in decontent, they are going to bombard you with a lot of questions. And you should expect a question on scopes. All right. So leak test it, If it fails, still go ahead and clean it. If it doesn't fail, go ahead and clean it and let it continue to the next stage of what? The cleaning process. All right. So leak testing, then clean, manual cleaning. We're using enzymatic detergent, using brushes, flash every channel. And then when it is supposed to be used, sterile or low temperature, they have to do that. And if it is supposed to be high level disinfected, then it has to go through that process, either using the machine that you do in the high level or you do the manual process. Okay, right. HLD for standard scopes and then sterilization for critical procedures. Then once it is done, you have to dry. If it is HLD, which is high level disinfectant, you have to hang the scope for the scope to dry. It has not. It must not have moisture or liquid in it to go to be used on the next patient. All right. If it is sterilized, you're good. You don't have any problem with that. And then it might be stored. If it is high level disinfectant, it must be stored in the appropriate cabinet or appropriate housing mechanism so that it is safe, it is protected, it is not exposed to outside environment where it will get contaminated. Next slide. Okay. So robotic instrument, we have seen that. So I don't want us to wait our time over there. Pre-cleaning of flexible endoscopes. So why do we have to do pre-cleaning? To remove gross debris. Supposed to be done in the OR. I said that. Supposed to be done in the OR. Blood, fatty tissues, human tissue that is done there on it is supposed to be removed in the OR before it gets there. And it's supposed to be removed by wiping it with a sponge that is infused with detergent. Okay, that is recommended by the manufacturer. Okay, suction channels should be what? Rinsed with clean water immediately after use. Again, that is supposed to be done in the OR. But I can promise you that they don't do it. Insert tubes or shaft must be, insertion tubes and shaft must be wiped down with enzymatic detergent solution approved by the endoscope manufacturer. They don't do it, but we are supposed to do that. That is the pre-cleansing stage. Now let's go to the next slide, please. Leak testing. You have to leak test it. There's a device. I can explain it for you, but you need to do it to understand what it is. So there's this device that venting, where we put the venting cap, you connect the device to that part, open up the channel that you want to test to see if it is leaking. Inflate, there's a bulb or a device that you need to put air by inflating. You inflate it, there's an arm that moves up and down. That arm, you inflate it to a certain point, leave it there, don't inflate anymore, and see whether the arm moves back. If the arm moves back, it means it's leaking. If the arm stays there, it means it's not leaking. But then it might be leaking, but the leakage is so small. So what you do is that you regulate the scope to see. As you regulate the scope, you bend it up and down. If there are any cracks in there, as you bend it, you expose it. You see that the arm will move faster. If you bend it and the arm is still staying where it is, and there are no bubbles showing up, when you put it under the water and you regulate it and you don't see any bubbles coming out, it means if bubbles are coming out, it means air is escaping. That is why you're seeing bubbles. If bubbles are not coming out, it means the scope is passed or it has passed the leak test. Next one. Next slide. So these are the cleaning processes of flexible endoscope. Rinse with water to remove debris, detach removable parts, immerse in enzymatic cleaning, all of that. Flash, okay. Wipe the exterior with lint-free we spoke about why it must be lint-free, because lint stays on, it can drop into the sterile field and then infect the patient. Use soft brittle brush, not metal. Insert long, flexible brushes to clear the debris in the lumens. Repeat brushing until the brush comes out clean, and then flush channels so that you don't leave lint from the brush. Okay, that's why we flush them, and then dry thoroughly. Next slide. Okay. Visualization, a quality program for cleaning verification. So visualization alone is insufficient. All right. Just by looking is insufficient. You can see out, but you cannot see the debris, the whole of the debris or biobedding that is inside. So it is recommended that cleaning verification method be done. So inspect both external and internal components. Monitor cleaning equipment performance if used. Ensure correct chemical dilution and cleaning parameters. That is, if you are using a machine that is doing the cleaning, that's what. And then it also will tell you how many gallons of water and how many liters of water or milliliters of what the chemical you have to mix, so that it will break down the fatty tissues and then the debris. Use verification tests for residual organic soil for microbial contamination. Yes, we call this Sonicheck. Some places that's how they call it, Sonicheck. So there is a commercially produced test strips that you you inject a solution through the lumen part of the channel, the opening part of the endoscope, and then you use a cap to collect the solution that you've injected, because the solution is going to flash the channel. So if there are any debris in there, meaning that it was not properly cleaned, the test strip will fail. It will give you a color chart that will tell you which one. If the strip looks like this, it passed. If it looks like this, it failed. So when you dip the test strip inside the collected specimen of the solution, and you dip the test strip in there, and then you leave it down for maybe, depending on what the IFU say, most of the time it says 60 seconds, which is 1 minute. After 1 minute, you look at the test strip, compare it with the chart. If it does not have the color that says fail, it means it passed. If it has the color that says fail, it means that it didn't pass. It means that it was not properly cleaned. So it has to be taken back to the decontamined gentleman or lady to do his part of the bargain. Next slide. High-level disinfectant. So you definitely will use some chemical, some solution of some sort to be able to do high-level disinfectant. High-level disinfectant is what is the reason why endoscopes are very, very infectious, okay? Because you cannot guarantee that it was really, really, really disinfected. That is why most of them, when you disinfect, you do high-level disinfectant, after 7 days, depending on the hospital protocol, it has to be disinfected again, because they feel that the chemical has expired. Therefore, it is exposed to outside environment and needs to be reprocessed. So some is 7 days. Most of the time, high-level disinfectant is 7 days. Then you have to reprocess it again. So you always see them having expiration dates on them. They tag them the day it was processed, and then they count 7 days from that time. So if today is 9th, and you process an endoscope via high-level disinfectant, it will be 7 plus 9, which is 16. So the 16th of March, the scope will expire. You have to reprocess it again. So that is how it is done. Okay, so after you have done all the pre-cleaning and what have you, and you do the HLD, that is how you tag it before you go and put it in the cabinet where it is supposed to dry. All right, next slide. These are the common. I want to ask for some help. Okay, I know it's 6 o'clock. We just want to see if we can wind it down quickly. Okay, so just bear with us. That so we can finish quickly and then we can all get out of here. Common high-level disinfectants. I can't say some of the names. I'm sorry. I don't want to promise anybody and I'll be able to, but these are the ones that is commonly used. The one in the middle, the OPA, you will hear it all of the time. OPA, 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 OPA. All right. Can somebody give it a shot to say it? Is somebody be bold enough to say it? We'll be like, oh, they teach, even the professor cannot say, let me keep quiet. All right. Or the teacher cannot say it. So these are the the commonly used high-level disinfectants that are in the system. The most common one you hear all the time is the OPA. That is not to say that you will not see other ones. They have new ones that are in the system. For the purpose of this study, the commonest one you will find is OPA. You will definitely get something related to that OPA. And let me just make this general rule. Regardless of which of these high-level disinfectants you use, if it is manual, you have to rinse the instrument thoroughly. Because if there is any residue left on the instrument, it can cause harm to the patient. So it has to be rinsed thoroughly. And then when you are setting it, for example, the OPA is set up for, I think, 2 weeks, 14 days. When you set it up, some of them you need to dilute, some of them you don't have to dilute. The OPA, you don't dilute it. You just pour it from the gallon or each housing container, and then you soak the instrument in the IFU. Most of the time, it's 12 minutes. You leave the instrument there for 12 minutes. You bury it inside the solution for 12 minutes. You have a timer. When the timer goes off, you go take it out and you rinse it thoroughly. And you rinse it with sterilized water or sterile water. Sorry, sterile water. Water that has been taken, ions have been taken out of it. It's sterile. So you rinse it thoroughly because it can burn the patient. So either of them, please make sure you rinse and rinse and rinse and rinse and rinse. So always check the scope manufacturer's IFU for disinfecting compatibility. That's what it means. All that I've said will be given by the IFU. Next slide. Next slide, data. All right. Now, if the endoscope is supposed to be processed through automated endoscopic reprocessor, it means it makes the work easy. Labor, your strength, your expertise is eliminated. You only need a good job from decontam, and then the rest of it will be taken by this machine. So you connect, but you still have to be able to connect the right tube to the right channel. If you mix it up, you damage it. So you have to be in service. So we have some of the automated reprocessors. We have Mediveda, which you get to know. In some places we have Astra machine. In some places they have Trophon machine. Okay, some of them are huge. Some of them are like fridge. Some of them are like a microwave. Some of them are like your portable washing machine. So you get to see all of them when it is in. So the Mediveda, the Astra machine, the Trophon machine are all kinds of automated endoscopic reprocessors. Automated means that the machine is doing the work. So the labor, the human part is eliminated. All that the human part does is to decontaminate it pre-clean it, flush the channels, and leave the rest of the work for the machine to do. All right. Next slide. Storage. Hang it vertically so that the excess chemical and water will drain off. Okay, you don't need that into the patient. Okay, ensure weight is supported and regulated, and angulation locks are off. Store in a dry, dust-free, ventilated cabinet. Okay, do not store movable parts, valves, caps attached. Okay, do not store them with the caps and this attached because it will prevent drying. Remove the water-resistant caps from video scopes. Ensure scopes do not touch each other in storage. So they each have slots that you have to hang them. So flexible endoscopic accessories, yes. Biopsy, forceps, water bottles, cytology with brushes, foreign body forceps. All of these are the things that are used alongside endoscopes. So the water bottle is there to flash, to clear the place for the doctor to see. Okay. If it's too bloody, they flash. Okay. To do that. The biopsy faucet is passed through one of the channels to retrieve something. Okay. So water delivers, star water must be delivered. It cannot just be any tap water. No. They have water in the OR that is sterile. It's not just any tap water. Okay. Your Voltic or your spring, Poland Spring or your Pure what's it called? Is it Pure Life or what? Purified water, whatever. It will not work. They have chemically, medically sterile water that they use. Next slide. These agencies also make contribution to endoscope. OSHA, protect workers from infectious disease or exposure. OSHA is on the side of the workers. They make sure that this hospital supply you PPE to do that you don't infect yourself and take home. Then Department of Transportation, DOT, regulate transportation of biohazard materials. CDC publishes infections and sterilization guidelines. So the CDC collects data and publishes guidelines as to how to get around it. FDA monitors medical devices safety and disinfectant approvals. EPA, yes, when you use the chemical, it goes back into the environment. Is this safe for all of us, or you are killing us slowly? So regulate disinfectants, okay, and environmental impact. Next slide. So basically, same thing, leak testing and what have you. Okay, next slide. All right. So we are now looking at the cost, why we must spend time to take care of it. Rigid average cost is not the real cost. Rigid rod lens endoscope, 3,000 to 6,000. The one they use for sinus and then the arthroscopy cases. Flexible fiber optic endoscope, 8,000 to 25,000. Advanced video scope with microscopes and ultrasound, 12,000 to 100,000 plus. Repair costs alone, large hospitals may spend about 750,000 per year on scopes. I'm sure my hospital, they do that. Community hospitals may spend 200,000 plus. 60 to 75% of endoscope damage is caused by improper care and handling. Proper care and handling and can be prevented. Is an act that can be prevented. Okay, it's something that we can work on to get it to stop. Consequences of endoscope damage. delay procedures, user frustration, and increased stress level, misdiagnosis, and potential patient harm. When it's damaged, all of these will impact negatively. Significant financial burden on the healthcare. You will not get bonus, or when you are crying for increase in pay, they will not listen to you because much is spent on replacing or repairing scopes. Next slide. So, daily use cycle of endoscope: storage, transportation, use in procedure, decontamination, preparation and packaging, and then disinfection or sterilization. Or you see endoscope going through all these processes, and every process care must be taken because of the cost and the impact it will bring if you don't do that. Next slide. Avoid improper storage. Next slide. It's loud, it's clear. You don't need much. I don't need to talk much. That's why I'm just avoid improper storage. Says that best transportation, do not put heavy instrument on scopes. We have said that. Put the scope in the container that it went there. Don't switch it. If you're in the OR, you always switch it. All right? They do that. Okay? And sometimes they don't care. They just spoil. They just want to get out. All right? So let them do that. But you get more of the time. You see, you will complain to your manager. The manager will go and speak to them. You will still come back because the person who did it the first time is different from the next person. All right? So look for that. Best practices: rigid endoscope. Hold the body, housing body, not the shaft. Okay? Flexible endoscope. Hold the handle while supporting the distal end. Where the lens is, hold it nicely. Don't let it be falling. Don't let it be swinging up and down and hitting the sink. It's going to damage it. All right? Trays must be secure to prevent dropping. All right? That is how it is transported. Don't just leave it. If the scope has a house, if the house has partitions, you have to make sure that you put it all the way it is and then transport it. Don't let it hanging or loose over there. Next slide, Director. I hope we can get to finish before I wanted for us to stop at 9:30. Sorry, 6:30. Common causes of endoscope damage during procedures. Yes, sharp objects on them, heavy objects on them, dropping them, forcing instrument through them can also damage them. Excessive bending, we said that. The stacking stuff on them can also cause that. All right. Next slide. Yes, wipe off. We have seen that. Decontamination guidelines from the OR. All of that needs to be done. Proper placement in transportation containers. Guidelines. Common damage. We have seen that. We just saw that the slide before. Next slide, Director. Okay. So critical inspection point. The distal tip. Check for cleanness. Check the distal tip. Make sure the light, if it is a rigid one, make sure that light goes through. If it's flexible, make sure that distal tip is not cracked and what have you. Most of the time, I always tell people, wipe it. I start with 70% alcohol. 70% alcohol. Wipe it out and with your lid-free cloth or towel before you put the tray together or the scope together. For rigid scopes, view the tray, lift it up and watch the light and see if you see through. Okay. For cracks, barrenness, or dark spots. If it is dark, it means it's not going to help the surgeon. If it's cracked, you will not see anything or the crack will deceive the surgeon to thinking that he's seeing something in the patient. Next slide. Sterilization consideration. The manufacturer determines the appropriate sterilization method, whether sterile or steam, and that will be spelled out in the IFU. Next slide. Again, you have to handle it with care because of the cost involved and avoid them having fluid entering them. Don't soak them for long hours. Okay, avoid dropping them on the floor. Once you drop a camera, if you drop your iPhone, you will not pick it up the same way. Okay, same thing as these devices that we deal with. Next slide. It costs a lot of money. That's all that I can say here. It costs a lot of money. It costs a fortune. And because of that, when hospitals are incurring higher costs for maintaining them, they don't, when you ask for raises, they don't want to give you. Next slide. Next slide. Yes, loaners. We said loaners are instruments that we do not have as a hospital or a facility. So we have to go, but we need it for a procedure. So we go to a third party or a manufacturer and take. All loaners are borrowed and we pay a loaner fee. It can be a camera, it can be a scope, it can be a rigid instrument like the one in the picture here. Okay. Because of the cost involved, we are not able to buy it, so we go and borrow. And maybe they are not doing such procedures every day. So when we need it, we go and borrow. And the borrowing can be done, you can borrow it from another facility that has it, or you can borrow it from the third party. Okay, so the borrowing has different sources. Maybe Mount Sinai has, for example, Mount Sinai has about 6 or 7 hospitals. If it's not in hospital A, you can contact manager in hospital B and they can supply you, or you can contact manager in hospital D, and then if they have it and they don't need it for that day, they can give it to you. You still have to let it go through, decontamine, clean, inspect, prep it, and then pass it through sterilization. All right, so next slide. Okay, so the loaner, when it comes from a third party, it has to be logged in. Okay, it has to be logged in by the instrument rep or the vendor rep or the vendor person who is bringing it. Sometimes they just let the drivers bring it, and then that's why they also have to be able to read and write. So they will log it in. It has to have the date and time of receipt, the delivery person's signature, the surgeon's name, the patient identifier. Some cases, some hospitals, they have that. Not all hospitals have the patient identifier. Okay, so it's not, don't go somewhere and insist that it has to have it. Every hospital has its policy of this, how loaners are logged in. But the number of trays the patient or the driver or the rep is dropping off. Okay, so because most of these log books are open to public, you don't want to have patient information there. So that's why most places you don't see patient information there. And as usual, they expect that you will inspect the loaner that is coming in. When they drop it off, it has to be treated, or it has to be cleaned, it has to be washed, it has to be soaked, it needs to flash those lumen pieces in there, and it needs to be put together and ready for you when the surgeon needs it. Okay, next slide. Same thing, just as I have said, decontamination process is the same thing. You don't cut corners, soaking, brushing, flashing, washing, and sonicking if need be. Next slide. So, BioBeddy, functionality. Sometimes you don't know how it works, so you cannot look at it. You cannot look at the functional part unless an in-service is done. But if you are lucky to know how it works, good. Use that expertise to further check If there are any cracks, see if you can, because it's a loaner, sometimes you don't know whether it's a crack or that is how it was designed. So loaners, most of the time, we just look for debris and then we send everything back as it is, because it's coming from outside, it's coming from a third party. We don't know, we don't want to do anything extraordinary to get it broken. Okay. Right, next slide. Same way, whether loaners, sometimes, most of the time, we wrap it or we put it inside a container and then we sterilize. After it has gone through cleaning and decontam and through the washer. Sometimes, depending on the nature of the loaner, it could be sterilized using high-level disinfectant or low temperature sterilization or high temperature sterilization. But then it has to be stored in a place where the traffic is low. Okay, it's not exposed to so much traffic. You have to, if it is a wrap tray, you have to lift it, you don't have to pull. If you pull, what is going to happen? You're going to create a hole in the wrap. And once a hole is created in the wrap, it serves as an entry point by viruses, bacteria, and the rest. And then it will contaminate the very instrument that you thought is sterilized and ready for use. So that means that you cause panic in the department, because they need it, they open it, there's a hole in the wrap. It means that it has to go through the process again. You don't want to do that. Okay, you don't want to go do that to your manager. After use, the vendor counts for the tray, but before he counts for it, because it is used, it has to be decontaminated and washed and cleaned before the vendor takes it, or the manufacturer or the third party counts for it to the place where it came from, and a fee is paid, but you don't get to know who pays that fee. Next slide. In conclusion, thank you so much. We are almost there. 31. Surgical instrument advance. As surgical instrument advance, because of advance in medicine, these get complicated, but their complexity can be handled if we take proper care of them, and we follow hospital protocols. We follow laid down protocols by professional bodies, or we follow the IFU of the manufacturer. The IFU of the manufacturer is at the apex, is at the top before all other protocols are coming. Okay, so always follow the IFU of the manufacturer, and if you do that, you increase the lifespan of these instruments. You save the hospital a ton of money. And then when you go looking for a raise, the hospital will gladly give you a raise, because not much was spent on repairs and replacements. So must stay current with new technologies and best practices, and adhere strictly to manufacturers' IFU regulation guidelines and proper education in handling of these complex endoscopes. All right, so powered instrument, endoscope, laparoscopic instrument, loaner instrument, all need special attention so that they can last longer, for more patients to be taken care of. And that will be the end of our lesson today. Thank you so much for your time. I know we went extra 33 minutes into your time. Thank you for your patience. I know it's been difficult for especially our Muslim brothers, but it's worth it. Okay, so we'll see you next time, next week.